All right, hello everyone, and welcome to UOA On Demand. Today we're going to talk about ACL injuries and the treatment of ACL injuries. My name is Charlie Gatt. I'm one of the sports medicine specialists at UOA, and I'm joined by my partners and fellow sports medicine specialists, Dr. Cris Beiro and Dr. Jeffrey Bechler. So, hi guys.
How you doing?
All right, so ACL injuries. Everybody hears about ACL injuries. They're very common. You hear a lot about them in sports, in the sports world. If you're watching Sports Center on TV and you hear that somebody on the Giants blew out his knee, it may mean that he tore his ACL. And most of us have known kids or high school athletes or college athletes who had the same injury. But the truth of the matter is, a lot of the ACL injuries encompass all ages and walks of life. So I just like to first talk about typical injury patterns that we see. So, Cris, maybe you could tell me, how would you describe the typical story that you hear about an ACL injury when someone comes into the office?
So typically a patient with an ACL injury would come in, it'd typically be a young athlete involved with a running or cutting sport, particularly soccer, football, skiing, basketball, in which case they did a low energy, non-contact twisting kind of an injury, and all of a sudden heard a pop and noticed swelling at their knee and wasn't able to continue. That's fairly what I see most commonly.
And Dr. Bechler, you take care of Princeton University athletes, and what about contact injuries? Dr. Beiro tells us about the non-contact, but what do you find with the contact injuries that you see?
So the contact injuries that I see, typically if they have an ACL injury, they'll have a combination injury. They'll have more than one ligament injury. So they'll have commonly an ACL and an MCL, or an ACL and a lateral collateral ligament injury, because they had contact at the same time that their foot was planted. So it's usually a more severe type injury if their foot is planted and they have contact.
Yeah. And we're talking, we've been talking a lot about the younger athletes, the high school and the collegiate athletes, but the truth of the matter is more and more people are leading active lifestyles. We have, the soccer moms playing soccer on the weekends, and, leagues of people in their 30s and 40s and 50s. Now, how about those people, Dr. Beiro? What are you seeing there with that group?
So it's highly variable what we see. As I mentioned, typically you would notice a young athlete with a non-contact twisting injury that suffers an ACL tear. But I think we've seen all comers, particularly in the older generation, who just want to maintain an active lifestyle, anywhere from recreational athletes to people who have an ACL injury from dancing, twisting their knee wrong, or getting hit by a wave the wrong way at the beach. So I think we see all kinds of comers there, and those lead to significant ACL injuries.
Right, and I think it's easy to think, when you get a little bit older, it's not that important. But the truth of the matter is, the people in these older age groups are taking their sports participation as seriously as some of the younger kids, and they've got to get out there and play soccer on Saturdays, or play tennis on Friday nights. So their knee health is just as important to them as it is to some of these younger athletes. So I think that's an important point, is that we realize that we're really seeing a bigger and bigger age span of people who tear their ACLs, and it's happening frequently in young and older athletes. So Jeff, as far as the patient comes into your office, and again, you told us it's the typical athlete comes in with a cut and a pivot and they feel a pop in their knee. What do you find is, on your examination, what are you looking for to make this diagnosis, and how do you go about evaluating the knee?
So most of the time, if it's an acute situation within the first couple of days and the person's coming to the office, their knee will be swollen. They'll have a significant amount of swelling. They're usually on crutches, and they're unable to put a lot of weight on it. And to some degree, they will have had discomfort, maybe taking Advil or Motrin and using some ice. And more frequently than not, they'll be accompanied by their parents, because they've been with them the entire time for the last couple of days while they've been going through this first acute phase. For the person who's has the injury initially and you're on the sideline, obviously that's much more acute. They won't have time to swell yet, and the examination will be much easier to do because there's no swelling. So you'll be able to determine an injury to the ACL in a better form when the injury occurs right away, as opposed to waiting a couple of days when they come to your office.
Yeah. And Cris, I think, we all, again, that's the typical story, is that young athlete. How many times or how frequently you're seeing people who maybe tore their ACL quite a while ago, maybe didn't know that much, didn't know that they did it. What's different about them compared to the athlete who comes in, 3 days after injury?
So a lot of times we will frequently see people who have a chronic ACL tear or a subacute ACL tear, either because they didn't know what their diagnosis was, or they just there was a delay in getting care for whatever reason. And those patients present quite a bit differently. I think the main complaint will be that of instability. They're walking and their knee just gives out from underneath them, and they find it difficult to do any kind of twisting motions or cutting motions, whether it's sports or just really walking, turning in the hallway. Other signs that we'll see, while we may not see that acute inflamed type of knee, we will see potentially a remnant of an effusion, so fluid in the knee, maybe not as pronounced as when it first happens, but it can still be there. And we'll also see potentially some atrophy of the quadriceps muscle. So they're because they're walking in a different position or trying to avoid using their quads as much, they will have a significant deficiency in their quads.
Yeah, I find it interesting how some people barely remember the injury that led to the instability of their knee, but they just know that every time they do not every time, but frequently when they do a twisting motion, their knee gives out and they can't explain it. One of the exam maneuvers that, is classic is a pivot shift, which is almost impossible to an acute injury, but it's a way of making the patient's knees shift out of place on the exam table. And so I'll do that, in the chronic ones, somebody who maybe tore their ACL a few years ago but didn't know it, but just comes in complaining of instability, and I can make their knee jump for them. And then I say, is that what happens to you? And they say, yes, that's it. And that alone, that tells you right there that that's the injury. So it definitely a very different examination, and you can really show the patient what's going on, and they know that feeling, like they know exactly what's happening on the field. So yeah, those are really important points in terms of the physical examination. I routinely get x-rays on these patients. Do you guys do that?
Absolutely.
And
Absolutely.
what do you look for? I mean, there's in both the young and the older patient, because again, we're dealing with both age groups, and I think the x-ray findings are actually, somewhat important, even especially in the older patients, to tell you the truth.
Yeah, so I guess starting in the older patients, we look to see what their alignment is and to see if they have any arthritis at the same time. Arthritis doesn't mean that they're old, it just means that their knee may have been through a lot of wars, and so they could be in their 30s, 40s, and 50s and still have some significant arthritis on the x-ray. So we certainly want to note that on the exam. And then when we look at kids, young teenagers, we're looking at their growth plates to see if their growth plates are opened or if they're closed, and whether they may have also, have a small fracture or a chip around the knee, which is seen on an x-ray and will give us a clue as to whether they had a significant injury to their ACL or not, just from the x-ray.
Right. Yeah, all really important findings, especially when you're trying to plan their treatment. Signs of moderately advanced arthritis may really change your treatment plan. And again, when we talk about older patients, we're talking 30, 40 years old, but if they have moderately advanced arthritis, we may have a different approach rather than if they have a very healthy looking knee. So those things are really important. Then, everyone, obviously the next step after an x-ray is an MRI, and almost all patients want an MRI, and it gives us a lot of information. It's a very important part of the workup. So Cris, why don't you explain a little bit about what you're looking for when you review an MRI, because it's more than most times. I think you probably know the diagnosis is an ACL tear. You're getting the MRI to confirm that diagnosis, but you're looking for that, and what else?
Well, absolutely. As you mentioned, I think right off the bat, with a good physical exam and history, you kind of know where this is going. And the MRI does help to confirm it. I think the MRI is very helpful with surgical planning as far as what you'll need to do. So as far as the ACL is concerned, we'll look for, particularly on the side images, a discontinuity or redundancy of the ligament that doesn't quite look continuous, that looks abnormal from the way a ligament should look. Additionally, we'll look for a pattern of bone bruising that can be seen with a rotational injury that can cause an ACL tear. And those bone bruises will particularly come up on the lateral femoral condyle and posterior lateral tibia. Additionally, we'll also look for any kind of chondral damage or meniscal injury, and potentially even some injuries to the collateral ligaments or the PCL as well.
Yeah. I think, the bone bruises are something that I like to show patients a lot, because when I explain to them where the bone bruises are located, it shows the magnitude, how far the knee comes out of place when they tear their ACL, because the bone bruises are pretty far apart, and for the bones to make contact at that location, it really kind of hits home with the patient's, wow, my knee really went out of place. And then meniscal damage, Jeff, why don't you talk about, the role of, how you use meniscus damage to maybe change how that might change your treatment plan,
Well, I
or
think,
the lack of it.
yeah, so I think it depends a lot on the age of the patient. Certainly, younger patient who has a meniscus injury at the time of their ACL, it may be repairable. And so based upon the configuration on the MRI scan, you may advise that the surgery be done, sooner rather than later. If the meniscus is torn and displaced enough so that the knee, can't get straight and is wedged in a certain position. So it's always important to look at the meniscus injury and assess whether it's going to change your plan for treatment for the patient, so you can advise the patient accordingly. And the same thing for an older patient or someone who's in 40 and has some arthritis. If they have a meniscus tear, we would want to also, advise them as to how we were going to plan their surgery as well. So it does filter into your surgical planning, and to some degree, in some cases, it can affect your timing.
Right. It definitely, if you have a repairable meniscus in a young person, the sooner you get to it, the better. But a lot of times that's going to move us right into the next talk, is the indications for surgery. So again, we have, younger patients and we have some older patients. And, I think most people come in and, once they've heard the term ACL tear, everybody thinks they need surgery. Cris, why don't you talk about your indications for surgery in the older patient to start,
Sure.
and how you go about that discussion with them?
I think it all comes down to what their clinical symptoms are. As you've mentioned with older patients, it really revolves around what their lifestyle entails. So if they're sedentary and just kind of have this as an accidental injury, then potentially there is a role for non-operative treatment, particularly as Jeff mentioned, if they're particularly arthritic and they're not prone to doing cutting sports or cutting maneuvers. That being said, I think the indications have broadened significantly over the past few years and include a lot of weekend warriors, recreational athletes, or people who just want to stay active and are able to maintain those cutting, twisting maneuvers or exercise. So in my mind, I think one of the main foci, it revolves around instability. So if a patient has instability and they want to just maintain an active lifestyle, then I think that's one of the major indications for reconstructing the ACL. Additionally, we also do look at some of the other concomitant injuries, such as meniscal tears, chondral damage. So if you have a knee that looks pretty good, we should try to maintain that as much as possible.
Yeah, I think evaluating their lifestyle is really important. I mean, every now and then you'll see the person who's never skied before, and they decide they're going to go skiing, and they tear their ACL. You say, well, we could do surgery to fix it. And well, I don't ever want to ski again anyway. So then you have to talk to them about, well, what else do you do? But maybe they play tennis or soccer or basketball. So really evaluating their lifestyle and talking about the impact of having an ACL deficient knee and the risk of instability, and also the subsequent damage if their knee gives out a lot. And then so that brings us to the younger patient, Jeff. Obviously when a young athlete comes in, they're almost primed to know that they need surgery. But before we talk into the indications for their surgery, is there any time that you would maybe either hold off on surgery or delay it for a little while, or tell a younger patient they probably don't need surgery?
I think that there certainly are those cases, Charlie. And, the hard part is that, like you said, most of the patients, when they come in, if they know they have an injury to their anterior cruciate ligament, they're coming in to talk about surgery, and they've already gotten down that road. But there are a percentage of patients, who might want to delay their surgery for any number of reasons. There are some, for example, maybe a senior in college who's the captain of their football team and plays wide receiver, wants to try to finish their senior year, and they have it done. They tore their ACL in practice in September. And so there is a role, if we educate the parents and educate the patient, to say, listen, if you want to try to complete your season, it's going to take you 6 weeks to get over this acute event. But we can try, if you want to try and brace it, we can brace your knee and see if you can play the last 3 or 4 games with your teammates, and then have the surgery after the season. So that's just one example of how you can tailor the timing of the surgery to the particular patient. I think it's important to do that because there's a certain percentage of patients who come into the office and they're going to get an ACL. And there's a certain percentage of patients, so let's just arbitrarily say they're 75 years old and they're not going to have their ACL done. And then everybody else is in the middle. And so you need to spend some time to figure out, is this person a patient who requires an ACL? And if so, what's the best timing and the safest way to do that? And I think it's important to educate them as to what their choices are.
Yeah, I agree. I think, Cris, staying on that same discussion, you have these young patients who maybe have an ACL, they've torn their ACL, they have no meniscus damage, they haven't done any damage to their articular cartilage, but we used to, all the talk was about, well, we're going to reconstruct your ACL so you have a stable knee, but how do you talk to them about protecting the structures that haven't been injured and why ACL is so important in terms of protecting them? Just kind of put a little light on that.
Absolutely, Charlie. That's a great point. Especially in younger patients, you want to preserve the cartilage that's there as well as the meniscus. And it's been shown, studies have shown that ACL injuries do lead to further chondral damage, further meniscal injury, particularly chronic ACL tear patterns can lead to medial meniscus tears, as well as iatrogenic cartilage damage. So I believe the studies show that after 12 months, you can have significant damage within the knee. So obviously having an ACL there to stabilize the knee would help. Even the Academy guidelines go so far as to say within 5 months of the injury is what's recommended if you're going to have an ACL reconstruction. So I would assume, and I think you probably feel the same way, that we're all pretty aggressive with younger patients as far as reconstructing the ACL, not only to provide them stability, but also to protect against future injury.
Yeah, I think driving that point home to the patients is important because, a lot of people say, well, I tore my ACL and I want to get it fixed so I don't get arthritis, but it's not the ACL tear that leads to arthritis at an earlier age. It's the subsequent damage to the meniscus or cartilage, like you talked about, that, we're trying to protect because it's those tears and that cartilage damage that causes the arthritis at a young age. So I think both the athlete and the parents need to understand it. We're not only doing this so you can get out and play, in the next season, but we're doing this for the long-term health of your knee. Because, if you look at the parents and what they do, some of them, they're so mortified that their kids have to have surgery. They don't ever go back and play sports again. But then, they also don't want them to end up limping around when they're 35 or 40 years old. And I think that's another, good point to make to the parents and the athlete, that this is for the long-term health of your knee as they start to, contemplate, the need for surgery. So, that's really important. Now we're ready to talk about surgery. We've gone over the indications for surgery and the patients in your office, and now we're going to tell them, what's going to happen to them in the operating room. So, Jeff, how do you describe, the ACL surgery and the different ways to do it, maybe?
So I think, the past 5 or 10 years, maybe even longer, patients and their families have become extremely educated with anterior cruciate ligament injuries and the treatment. And the majority of the patients, by the time they come into the office, even if it's just a couple of days, they have a lot of already education. They have a lot of preconceived ideas of what to expect. And so my job is to educate them as far as what they've learned that is correct and the stuff that they've learned that maybe is a little bit different from what they've been told. And so each patient has a discussion. We talk about the plan for surgery. We talk that it's an outpatient procedure. Patient goes home the same day. It's done typically at a surgery center. The patient's given a pain block so that they have very little pain, and typically don't use narcotics or Percocet at all. They just use Advil and Tylenol for the majority of the time. We talk about graft choice, which is a big portion of the discussion as far as what type of a graft we're going to use to make a new ACL. Because as you know, we can't repair the ACL, we can't sew it back together, so we give them a new one, and we take a piece of tendon from around their knee or a piece of tendon from a cadaver to substitute or to reconstruct the ACL as it is. And so we spend some time talking about graft choice. They have some ideas as to the graft choice a lot of the time that they want to have, and I tell them why that's a good choice or why that may not be a great choice for them. But for the most part, we move through the surgery as a one-day event, but the biggest event is obviously afterwards, where they have to do, rehab and be on crutches for a while, which we'll get to in a little bit.
Yeah. So Jeff, for example, I think a great point that patients really are educated these days, especially the athletes. Most of the athletes have already, 2 or 3 of their teammates have already had ACL reconstructions, or their sisters or their brothers have had ACL reconstructions. So, they don't come in naive, that's for sure.
Yeah.
I think what surprises me most is how much they know about the different graft choices. I think it is worth a couple minutes, Cris. Maybe you could talk about, what is your go-to graft, and maybe why would you choose one graft over another for somebody? So I think these things are important. It can become very complex, but maybe just a few minutes on that.
Absolutely. And I definitely agree with Jeff that I think when you're talking about surgery with patients, shared decision-making is very, very important. A lot of patients do come in very educated about what the procedure entails and what kind of grafts should be used, or what they've spoken to so many people, or as you mentioned, family members that have already had ACL reconstruction. So it's definitely important to kind of talk these choices through with the family, and to let them know your rationale for why you choose what you choose and what you plan to do. That being said, in my practice, I typically take a very individualized a la carte kind of approach to each patient, depending on what their needs are. And different grafts, while I would say that for the most part, literature shows that they're somewhat comparable, there are pluses and minuses to each. So for example, you can use what is considered technically the gold standard, which is a bone patellar tendon bone graft, which is taken or harvested from the front of your knee, taking a piece of bone from the patella, your kneecap, and taking another piece of bone from your shin and the ligament in between, and using that to reconstruct your ACL. You can also take 2 of the hamstring tendons that are on the side of your knee and reroute those to make a new ACL as well. And one particular tendon that's gained a lot of momentum over the past few years is a quad tendon graft, which is where you can take a piece of the quad tendon right from the top of your knee, with or without a piece of the kneecap as well, to use as an ACL. And I think different graft choices depend on the patient. There's also allograft, not to forget that one. Older patients who may want a shorter recovery period, or not as much postoperative pain in a sense, may opt for an allograft, which is a cadaver graft. And there are different types of allografts as well, similar to the ones that you can have as the ones that you harvest from your own body as well.
Yeah, I think the allografts or donor tissue is certainly very suitable for maybe some of the older patients. Number one, it hurts a lot less, right? You're not taking their own tissue to reconstruct the ACL. Older people, the patients who are working, they have to get back to work. That may play a role in it, and the outcomes of those are as good as, if you use their own tissue. So there's a lot less morbidity in using an allograft. But, at the same time, we don't want to use those in the younger high school and collegiate athletes, because all the information tells us that the allograft failure rate is 30% higher than if you use their own tissue. But we're not seeing that difference in the kind of the post-college athlete. People are out getting a job and just working on the weekends, and weekend warriors. So I think it's a good choice for the right patient. And I think every graft is a good choice for the right patient. I think, like Cris said, the patellar tendon is the gold standard. But Jeff, is there any patient that you might say, patellar tendon's not the right choice for you in terms of the younger athlete?
Sure. I think if we look at just classifications of athletes, harvesting the patellar tendon from the front of the knee will cause some discomfort if you kneel a lot or if you squat a lot. So it's been my experience that if there's a wrestler who tears their ACL, we probably would steer away from a patellar tendon and go more towards the hamstring because they're on their knees a lot. Likewise, maybe a baseball catcher, someone who's squatting and on their knees a lot would be somebody who I might steer towards a hamstring or a different graft choice because the patellar tendon would be tender for a while and would delay perhaps their ability to get back to play their sport.
And Cris, what about the more petite patient who's an athlete like a gymnast and hamstrings for them?
So that always poses an issue, particularly because hamstring width has been shown to be correlated or has shown some correlation with instability and failure of the graft. So we really want, if we see a patient who potentially might not have as robust a hamstring tendon as we would like, there are different methods we can use if we are taking the hamstring. We can fold it over multiple times to create larger grafts. We can also augment it with cadaver grafts, or as you mentioned, use an alternative graft. In particular, like a quad tendon graft is always suitable for that kind of thing.
Yeah, I've definitely shied away from using the hamstrings in those smaller patients. Cosmetically, actually, the incisions are nicer sometimes, but you have to do what's right for the patient. I think that's in those smaller patients, we try to avoid the hamstring as a graft choice. So now, surgery's gone well, and now the next question the patients always have in the office is, well, what's rehab like? Like, what happens to me after surgery? So Jeff, why don't you kind of run through what a typical rehab would be like for a patient who's gone through ACL surgery?
So a typical rehab program, we actually talk about ahead of time because I wanted to make sure that they know that this is the biggest portion of their surgery is actually not the hour and a half or 2 hours of the surgery, but the next 6 to 10 months. And so the patient is typically on crutches until they can walk normally, which is around about 3 to 4 weeks they're on crutches. So that's the biggest segment of their life that's inconvenient, where they can't be independent. So they got to prepare to be on crutches for about a month. They start physical therapy within the first week to attain that ability to get off crutches and walk normally. You keep them on crutches, or at least I keep them on crutches until they can walk without a limp, because then as long as they're walking normally, every step is a step of rehab. If they're walking normally, as opposed to if they're limping around, every step is really not helping them recover. And then the general goals are to be able to run or jog in about 3 months, to get back to their functional sports, maybe doing fundamentals at 5 or 6 months, and then competing sometime after that, somewhere between 8 and 10 months, competing in scrimmages and those types of things where things are uncertain and the activity is more competitive. So it takes a long time.
Cris, what do you think? What are some of the accelerations you've seen in the rehab techniques over the years? I do think people are doing things sooner than they used to a while ago, getting on an exercise bike and as early as 10 days, or doing some simple closed chain exercises like mini squats or mini leg presses. Like, what are you doing in your rehab protocols to accelerate them safely, and try to get them back to normal sooner?
So absolutely, I think it's a variety of things, and I think as the literature continues to put out more information about what's acceptable and what works, that definitely changes my practice. I would say that we brace, or at least I do, even though there's not too much literature behind it, but I do brace in the early postoperative period to protect patients from any kind of instability episodes, or even just because their quads are so weak. So we want to make sure that they're stable and that nothing happens during that time. And also as a function to maintain some knee extension, because sometimes patients will tend to lose a bit of extension as they kind of flex their knee to feel more comfortable. As far as exercises, a conservative approach might be to typically use closed chain exercises throughout, involving open chain exercises such as knee extensions on a machine, and incorporating them fairly early into the recovery period, sometime around 6 to 8 weeks, can help with strengthening. As well, we look at running and in a straight line without twisting or cutting maneuvers, and that can also help to increase range of motion and strength.
Yeah, there's no question that everyone's always trying to push the limit and get everybody back, but the consensus is that the average return to sports, full participation in sports, is around 9 months. I think I usually will tell my patients it's anywhere from 6 to 9 months, or maybe a little bit longer if it's a more complicated recovery, but it's usually pretty reliable. I also think going to a physical therapist that's is well versed in rehabbing ACL patients. I think the therapists tend to really like taking care of these patients because they're motivated to get better. Once the therapists see the patients are motivated, they're motivated to help them get better. So they usually have a really good relationship. I always like to prescribe 1 or 2 visits of what is referred to as prehab just before surgery, because I think it actually establishes a relationship between the therapist and the patient before surgery, so that way when they start therapy 2 or 3, literally 2 or 3 days after surgery, they've already met each other and it's not a shock to the system. And I think those 1 or 2 visits before therapy are very valuable for after surgery. So I like that a lot.
I agree, Charlie. I think, in addition to developing a relationship, everything is new for these patients. And so going to a place that they've already been to, they say, hi, good to see you again, and then while they're doing their prehab, usually if they're going to a busy rehab facility, they may see other kids who are in various stages of recovery, and they can be pointed out to them that this patient over there is 6 weeks, that one's 3 months. And so the patient who hasn't had surgery can get comfortable with where they're going to be at a certain period of time because they see another patient who's there already.
Mm-hmm. So now, surgery's gone well, rehab's gone well, and now we're in that, 7-8 month period of time, and athletes anxious to go back. You're anxious to send them back, and what are you using any specific defined criteria? Is it a gut feel? Like Jeff, how do you decide when an athlete can go back out on the field?
Well, from the first time they ask me to the time they go back, I say no about 4 times.
That's a really good point.
But what we do is we get them on a functional program so that they start to replicate some of the sports-specific activities they'll be doing. So if they're a football player, we have them do some fundamentals with football. If they're a basketball player, we'll have them do jumping and fundamentals, dribbling, and doing things on what they call ghost drills, just pretending there's a defense and there's not a defensive person there. And we have to take them through all these different steps. Usually they'll have an athletic trainer if they're in college. To some degree, they'll have one if they're in high school. And we have to, measure their ability to do these things before we advance them to the next level. And they have to do them painlessly. And at the same time, they're still doing their rehab following the surgery. So they have to do both things. They just can't resume their sport. They have to resume their sport and continue to do rehab.
Agreed. That's a really important point, because the last thing you want to do is send them back too early and not ready, and then have them re-tear their graft because their knee wasn't ready. And then everyone, I think in the past, putting patients in an ACL brace after surgery was very commonplace, but these days even insurance companies are starting to question the need for a brace. Cris, have you changed your using a brace when you return them to play?
So I have, to a certain extent. I agree with you. I think nowadays the insurance companies are definitely a little bit more vigilant about brace use after play. But I think if it's a cutting or twisting kind of a sport, whether it's football, basketball, I will have patients return with a brace, at least in the early or semi-early post-operative period, any kind of period before a year, I would say, which would particularly worry me. And then afterwards, just kind of transition out of it.
Yeah, I agree. I think when I tell the patients, you tell if they can't get a brace or they don't want a brace. I also feel like I can reassure them. I said, look, if ACL braces could prevent you from tearing your ACL, we just have all the kids playing with 2 ACL braces, we'd stop doing all the surgery. But they actually can't. They don't prevent an ACL tear. But there's definitely a feedback mechanism where the braces make the patients feel more stable, or even playing against their own teammates in practice. Right? They have the athlete out on the field with an ACL brace. At least his own teammate isn't going to slide tackle that leg. He's like, wow, this guy's just coming back from surgery. So it's also a little bit of a warning, and that kind of getting people through that transition of that gradual return to sports, because you don't just turn the switch on, right? It is a period of time that you have to work through before you become out on the field going 100%. And that's always my criteria. When I talk to the patients about, are you ready to go to play? I say, if I told you today you could go out and play, do you feel like you're ready? And if I sense any hesitation from the patient at all, I tell them, look, then you're not ready. Like, you really have to feel like you're ready to go out there, because they're all apprehensive about it. In the first season back, they're all a little nervous. Am I going to re-tear or something like that? So I want to see a lot of that's one of my main return to play criteria, is how confident is the patient that they're ready to go back. So cool.
I would also just echo that bracing and a gradual return to sport also plays a role with the graft type. If we look at graft healing and ligamentization, that takes time, particularly with the type of graft you use. If you're using like an allograft, for example, a cadaver graft, that can take a lot longer to heal or become your new ACL, in which case we want to protect it for quite a bit longer.
Yeah. But I think, it is a very highly successful operation. I mean, I would tell you that, when I talk to patients about the operation, I'd say, if surgery's, going to go well, you're going to be motivated, work hard to rehab. This is not a career-ending injury anymore. This is an injury that, like the high school kids, they're like, oh, now once the college coaches find out I tore my ACL, I'm never going to get a scholarship. But the truth of the matter is, a lot of kids are coming in with ACLs injured in high school. So it's not really that, I think it's a very great operation. I think that being able to reassure the patients, at the time, like Jeff, you said in the office, that whole conversation happens before surgery about what's going to happen for the months afterwards. And I think one of the most important things is to reassure them that, they're going to be okay, that they're going to be back on the field and, playing, the way they used to play. I feel confident saying that. You have any thoughts on that?
Yeah, I think it's very important that you tell them from the very beginning that this is, it's a terrible thing that happened to you. And yes, it's going to be stressful and inconvenient for a period of time, but that period of time is fixed and finite, and you'll be back playing again next year. And I also often, compare it to, it's like, it's better than a concussion. I said, you get a concussion too. I said, and you don't know when you're going to be back. And we keep on to doctors. Nobody knows. There's nothing concrete. I said, this is a terrible injury. It takes a long time to recover, but it's been worked out, and you'll be back playing again.
And I'd also add that it's just very gratifying to see some of these patients after their post-op period to just come back and say, hey, Doc, I ran again for the first time in months, or I played this sport for the first time in months, and I feel great. And, nothing beats the smile on their face when you see that.
I want to thank everybody for this evening. I think we had a great conversation about an injury that gets a lot of notoriety in both your communities as well as on television with pro sports. And it's a part of life that, I think in sports medicine, like Dr. Beiro said, it's kind of very gratifying to take care of these patients and see them get back. So, if you've had an injury to your knee, if you have that classic pop in the knee, when you've had a twisting injury to your knee, or you injured your knee a few years ago and ever since then it feels unstable, that's the type of knee injury you want to, seek out an orthopedic, evaluation. So, give us a call at UOA. You can find out how to make an appointment at uoanj.com, and there's some information here for you to help get you into the office and take good care of you. So thanks to everybody for your time, and have a good night.